All right, we'll give folks just a moment to start trickling in from the waiting room. All right, everybody, welcome to the final session of the 2024 Washington Poison Center's Overdose series. This is our final reminder that if you want a certificate of attendance, we will be happy to get you one, but we need you to fill out the survey that will soon appear in the chat box. Also, please enter your questions into the Q&A box, and we'll address those at the end of this session. It's my pleasure today to introduce Dr. Abby Winter. Dr. Winter holds teaching, research, and leadership positions at the University of Washington. Her focus is largely on older adult populations and pharmaceuticals, and specifically how to optimize medication use in older adults. Dr. Winter teaches in the schools of pharmacy and nursing at the University of Washington. Dr. Winter will be presenting on medication overdose considerations for older adults, a very important topic. And I want to thank you all for joining us, and also thank you, Dr. Winter, for presenting today. And please take it away.
Great. Thank you so much. And thank you everyone for being here today and what I understand is the final session of the final day of this series. So hopefully we can go out with a bang today. But our goal today is to talk about medication overdose considerations for older adults specifically. I know often when we think about the Poison Center, our biggest thought is kiddos, and that's the ones that we're worried about. But anywhere from 10 to 20% of calls to the Poison Center end up, at least in Washington, end up being for older adults as well, and for a variety of reasons. And we'll talk about some of those today. We'll talk about just aging in general and medication use and ways that we can help keep our older adult population safe. For the purpose of this talk and in general, we refer to older adults as those 65 and older, but we all know that there's maybe a young 70 or an old 58 or something like that. So it's not an exact cutoff, but in general, when we're talking about older adults, 65 is about where we have that cutoff. So we know that older adults face unique challenges when it comes to medications, and those challenges increase as medication lists grow. Now, if anyone here is an older adult themselves, cares for an older adult, has worked with an older adult, we know that those medication lists grow as we get older. So overdose, specifically accidental overdose, is particularly concerning for our aging population. So as I said, this session is going to discuss different challenges we face as we age, ways to prevent or reduce the risk of accidental overdose in older adults, and then strategies to reduce harm if, unfortunately, overdose occurs. So let's talk about medication consumption. Older adults, unsurprisingly, are the highest consumers of medications. So as we reach age 65, the percentage of the general pharmaceutical industry is taken up by older adults, and it gets higher. The National Center for Health Statistics conducted a survey of older adults about their medications and medication use. And so some interesting facts here. 90% of people 65 and older take at least one prescription drug. Most folks will look at that and say, of course, and probably way more than one medication. More than half of people age 65 or older take 5 or more medications. About 20% of people have 5 or more chronic medical conditions. And that's important to note because as we're diagnosed with more conditions, drug therapy tends to follow it. More than 40% of people age 65 plus take at least one over-the-counter medicine and at least one supplement. So we often think of OTC, over-the-counter medications and supplements as like natural and thus not harmful. But we know that that's actually not the case at all. There's still the chance for drug interactions with those. There's still a chance for toxic effects if you take too much. So all of these things are important to just put in the context of medication use for older adults. I will note that this study is a little bit outdated now, but that I would expect that these percentages are even higher as the years go on. So maybe some of you have heard of the Beers criteria. If not, it's not a huge need for today, of course, but the Beers criteria collects experts from across the country to come up with medications based on the year's worth of research, medications that are harmful, are potentially unsafe, or need additional monitoring for our older adult population. So, one of the expert panelists from the Beers criteria had this quote that said, medications play an important role in the health and well being of many older people. That's undeniable. They're a mainstay of modern medicine. We use medications for a lot of good things, like some of them listed here: correcting life threatening illnesses, reducing future risks, relieving symptoms. But medications also come with risks and side effects, which, in the context of the Poison Center talk, you would expect us to be discussing today. First, I want to talk about this word called polypharmacy. This is often defined as 5 or more medications per day. As we see polypharmacy, we see an increase in the risk of adverse reactions to medications because the more drugs we take, the higher the risk of drug interactions. Research has also shown that patients that take between 5 and 9 medications have a 50% higher chance of an adverse drug interaction. And when folks are on 20 or more medicines, there's almost a 100% chance there's going to be an interaction. So again, those bigger medication lists, including the OTCs and supplements, equals more adverse events for medications. Accidental overdose is an example of something called an adverse drug event. So an adverse drug event is an unfavorable or unintended reaction or symptoms that are associated with the use of a medicine. So in other words, it's harm that's caused by a medicine, even if we're using it as prescribed appropriately and at the normal dose. So as we get more medications, are we just assuming that we're going to have more problems? Possibly. So with each additional medicine that's added, we increase the risk of potential harm in older adults. And some of the biggest things we see here are the increase in risk of falls. And we know more falls means more broken bones, can also increase the risk of fatality. We see more frailty with more medications, mortality, exhaustion. Cognitive impairment can be a result of certain types of medications, not just we're getting older. And then the same with decreased physical function. We often see some of these things and think, oh, these folks are just getting older. Of course, they're going to experience them. But often these things can be tied to medications, especially multiple medications. The good news, most adverse drug events are preventable, which is great to know, but specifically accidental overdose. So let's touch on that a little bit more. Medicines can be toxic if you take too much of them. That's a generally well understood concept. Often it's because we're taking more than our body can process. So we also know that overdose is thought of as a poisoning. So medicines can also be toxic if you take them at the same time as other medications or substances, causing that interaction. We may be familiar with that term. And again, an overdose is taking a toxic or a dangerous amount of that medicine. An overdose is accidental if it was unintentional. So this is just sort of setting the stage, things we probably all agree and understand, but something to note as we're moving forward. One thing I think is important in the context of aging is also that you can be on a medicine and a dose of a medicine for years, decades even, at a younger age. And then suddenly, as we get older, that medication may not be safe any longer. That dose of the medicine may not be safe any longer. Because there are different aspects of our bodies that change as we age. Even if you're perfectly, quote unquote, healthy, your kidneys don't work as well as you get older. And we rely on your kidneys to kind of process a lot of our medicines. So things that might have been fine in your 40s, maybe not so much in your 60s and 70s. And that is both a difficult concept to understand for some people because it's been safe for so long. But that shows us how that accidental overdose can really happen without any other outside force besides time. How do these accidental overdoses happen? This is specifically talking about our older adults, but could probably be generalizable for other populations as well. So sometimes a medication is just not taken as prescribed or not taken as intended. The other option, though, is when a medication is taken as prescribed, but there are other factors at play. So it's important to sort of target this from multiple perspectives. And it's important that patients educate themselves, providers educate themselves, and our providers are educating patients, and you folks are also educating the public. So, for an example, when a medication is not taken as prescribed or intended, what could that look like? The wrong number of pills is taken or the wrong volume. Maybe you miscount, you forget how much you're supposed to take. Taking it the wrong number of times per day. Maybe you're taking your twice a day medicine and you accidentally take a once a day medicine an extra time. Continuing to take a medicine after it's been discontinued or stopped by the prescriber. So let's say you go into the office and they say, hey, you no longer need this medication. Or maybe they're a really great gerontologist who says, now that you're older, we know this medicine's not as safe anymore. And so they try to take it off or deprescribe it. If you go home and then continue to take that medication, you could introduce additional problems. Sometimes folks just take the wrong medication. Maybe it was someone else's medication in the household. I've had folks who, like a husband and wife, take the same drug, but different doses, and they see the name on the bottle, the drug name on the bottle, and maybe grab that one instead of their own. Could even be a completely different medication you end up taking. Or maybe you just grabbed the wrong bottle of your own or the wrong device. So, as a certified diabetes care and education specialist, I work with a lot of patients with diabetes. And as you could probably imagine, things like insulin have a high rate of potential drug problems or drug interactions and wrongful use. So, I have encountered more patients than I can even count, friends, family too, who have used maybe a mealtime insulin when they intended to use a long acting insulin. So maybe they took a really high dose of a drug that's going to drop their blood sugar really fast. And that's really scary. So they all that they did there was grab the wrong gray pen because maybe one is a gray pen with an orange writing and one's a gray pen with blue writing. Something really easy to mix up. And we'll talk about kind of how to overcome some of these difficulties too. So what about when a medicine's taken as it is prescribed, but there's other factors at play? What could that look like? Could be an unknown interaction with another medicine. So, for example, if you are taking drug A, drug B comes along, it could make drug A work better or have a higher amount in your body than what you thought. Or the side effects of drug A could suddenly be worsened when you take drug B with it. We also see interactions with other substances like alcohol or food. A big one people think about is grapefruit juice tending to have some interactions with medicines. And then, as I alluded to earlier, we see changes in our body despite anything we're doing otherwise, like our kidneys, our function decreases as we get older, and the fat distribution in our body looks different when we get older. And there are certain drugs that like to go towards fat and some that don't, and that can also make the drugs work differently in our bodies. So, a lot of common errors that can lead to accidental overdose could be something like your pill box gets filled incorrectly. And we'll talk about pill boxes in a little bit. There's kind of a pro and con to consider with that. But being able to educate folks about that, making sure they're filling them appropriately or have someone double check it. I often will have patients take a picture of a correctly filled pill box so that they can reference that. Some folks may forget if a dose was taken and they end up taking double the dose because they'll take it again saying, oh, I don't think I took my purple one this morning. But though that is a great reason to call the poison center and say, hey, what am I supposed to do about this if I'm not sure if I took a dose or not? Those drug experts and poison experts will be able to tell you whether or not taking an additional dose is harmful or potentially harmful. Sometimes a new prescription gets filled when you've changed the dose of a medicine because anyone who's been on a drug knows that it's pretty rare that you start on a drug and a dose and stay there for the rest of your life. Maybe your blood pressure changes, maybe your thyroid lab changes, and so does your drug. So if you are supposed to be on 100, but you've got the 50 milligrams at home, or vice versa, and you grab the wrong one, all of your care team thinks you're on the other dose and things could get a little wonky. Maybe you didn't remove that old bottle, or maybe you put the new one in with it if you fill a pill box. Another potential downside to pill boxes, filling them ahead of time. If you get some changes in your medicines, it's often hard to keep track. Sometimes we have folks who will be taking a medicine that goes by a different name, but it's actually the same drug or the same ingredient. That happens with prescription medicines if we have a brand name and a generic. But another example that folks may be more familiar with is if we think about over the counter drugs. Let's take Benadryl, for example. Benadryl is an allergy medicine, but people often use it for sleep. It's available generic or brand, but then drug companies are like, oh, we can capitalize on this. And they said, let's make a sleep aid with a different brand name than Benadryl. Um, but it's the same drug. ZQuil, that's literally just Benadryl. So let's say someone says, oh, I've got allergies. They take their Benadryl. Oh, I'm having trouble sleeping at night. They take their ZQuil. They're the exact same medication with two different names. Very quickly, we could have problems with that. So as I alluded to there, over-the-counter medicines also can have potential issues because they may have ingredients that are the same to what the patient's already taking or even very similar, and it's hard to realize that without having a professional overseeing your medicine list. And over-the-counter medicines can still cause drug interactions even though they're not prescriptions. So, some of the commonly reported medications involved in accidental overdose, just kind of generally accepted by the healthcare community, are opioids, acetaminophen, which is Tylenol, insulin, which is what lowers our blood sugar, and then blood thinners. So, these are not necessarily tied to poison center calls, but these are things that maybe they're managed at home or they call their doctor about it, an ambulance call, or a hospital or emergency room visit. But this is kind of what we tend to think of. So now let's see what's actually involved when we look at calls made to the Poison Center. So this data is from the Washington Poison Center calls from 2010 up until 2023 in adults either 60 or 65 plus. That was a little ambiguous there, but the categories of medicines that have the highest number of calls to the Poison Center are cardiovascular drugs, which are heart medicines. So things that maybe help with your blood pressure or cholesterol or those blood thinners are all kind of considered those heart medications. Analgesics, which are just pain relievers. So that could be something like Tylenol, which is over the counter, or it could be other pain medicines like prescription pain medicines. Hormones are actually another one. And this doesn't mean that they necessarily resulted in harm being done to a patient, but calls were made with concerns. Antidepressants are up at the top. Household cleaning substances was in there. I wanted a complete list, even though it's not truly a medication. Anticonvulsants, which are seizure medications. And what's tough about seizure medicines is they have such a narrow place where they are safe and effective. If you get too much, you can get there really quickly, or not enough, it's not going to work. So it's really narrow and hard to work with. And then the last one is sedatives and antipsychotics. So sedatives are ones that are like more calming to the body, and antipsychotics for mental health concerns that some folks have. So the specific medicines that are identified that I think are helpful to kind of understand are beta blockers. So those are generally used for hypertension or high blood pressure, but can also be used for heart failure and other concerns with the cardiovascular system. Hypoglycemic medicines. So those are medicines that lower our blood sugars. When you have diabetes, our goal is to bring your blood sugar down to normal, but if you take too much of them, your blood sugar goes too low. And a low blood sugar is actually right now way more dangerous than a high blood sugar and can cause you to pass out or have a seizure or lose consciousness and can be really unsafe. Anticoagulants are also blood thinners, another name for that. Tylenol or acetaminophen. ACE and ARBs. So those are fancier terms for some blood pressure medications. And then lastly was the pharmaceutical and illegal opioids in anything that was over 2% of the calls that came in. So those that I bolded there are where the data matches what's generally understood as culprits for potential risk and harm in older adults. So, what are some of the reasons for calls relating to medications? So, as I said, they don't always end up with like unsafe uh, results. But of those that do, the top three were from adverse drug reactions, intentional abuse or misuse, and then unintentional therapeutic errors. So adverse drug reactions has been pretty consistent across the board since 2010. About 5 to 6% of calls that come in relate to that. Intentional abuse or intentional misuse remains pretty low, around 4% total of our calls. But what I thought was wild, almost half of the calls that come in are from an unintentional therapeutic error. Almost half of calls in 2023 were that. So a common example of that that we may be able to kind of relate to as a society is back in I think it was like late 2020 or early 2021. I'm sorry, late 2021, early 2022 when Paxlovid came out as a treatment for COVID. Initially, only select pharmacies had access to this drug. So let's say you normally go to pharmacy ABC, and they know all the medicines you take, but pharmacy X is the one that has the drug you need. So you go to them, you try to remember the medicines you're taking, but you don't know the whole list, or you forget some, or maybe they don't ask, and you get that drug prescribed. You start taking them all together. Now, we found out that Paxlovid, we knew that Paxlovid had a component in it that had a lot of drug interactions. So if this pharmacy dispensed a medicine to you, not knowing the huge list of drugs you were on over here, there were a lot of interactions that were reported around that time, until Paxlovid was made more widely available. That's one reason it's important to try to stay at the same pharmacy when you can, because they do those safety checks and look over that for you. So while Paxlovid was really high in that 21-22 timeframe, it then went down as a culprit for some of these calls because we were able to do more of these checks before those drug interactions came to a head in the patients. So unfortunately, we know that overdose is sometimes intentional. So those reports I think are sort of important to look at here. Intentional or suspected suicide was the name or the category given to those calls, as a reason that someone would call. And it has been increasing significantly since 2010 in our older adult population. So even though it's right now, or in 2023, there are 215 calls per year, about 5% of total cases, it's still more than double what it was in 2010. In 2010, there were only 75 calls, and that was about 2.5% of the total calls. So that's something to keep in mind as well, that not saying that anytime there's an overdose or a concern, we then assume it's intentional, but know that that is definitely something that's on the rise. So we're going to talk about some of those big categories of medications that can cause are more likely to be involved in overdose, whether intentional or unintentional, and then what that overdose may look like, and easy strategies potentially that we can employ or be aware of to help overcome that. So first are opioids. Opioids are a class of medicine. Sometimes they're called narcotics, but examples of them are oxycodone, hydrocodone, morphine, fentanyl, codeine. We've probably all heard of these. They help with pain. They're really good pain medicines. They also help increase the feeling of pleasure, and they cause drowsiness. So some pros and some cons there. If the doses are too high for opioids, it can slow your breathing or even stop it, can decrease your heart rate. So you could see how we could quickly get to that point. If you feel like taking more is going to make you feel better, we can get to that toxic rate quickly. We see an increased risk of adverse events with opioids if we take them with alcohol or benzodiazepines. Benzodiazepines are medicines generally used for anxiety, sometimes appropriately or not, used for sleep. Things like Xanax or alprazolam, Valium, or diazepam. But that, along with an opioid, we see a lot of issues of drug interactions and potential overdose leading to fatality. Antipsychotics can also have a big interaction with opioids. So some of those would be like risperidol or Seroquel or Abilify. What's difficult about opioids is that feeling of pleasure that comes as a side effect of taking it can also lead us to wanting more. And that's why that high risk of addiction comes along with opioids, and they are such a restricted class of medications. There's also a big stigma, though, with opioid use and opioid use disorder, and that's important to address. Often this can occur even when people are taking it as prescribed. So education about opioids is really important. So someone could be taking their opioid as prescribed for legitimate pain, and could end up in a state of a toxic amount or an overdose. And so making sure we're also realizing that not all opioid overdose is intentional. So if someone is experiencing this, what could it look like? Those small, what we call pinpoint pupils, are often a telltale sign. Patients could be falling asleep, losing consciousness, their breathing is slowed, or maybe they've stopped breathing. We could hear choking or gurgling sounds. They're maybe a little more limp, cold and clammy skin, or maybe even blue lips or nails. So the treatment, I don't want to go into too much detail about this because I know there are a lot of programs from the Poison Center that are really great at promoting the use of naloxone. But just to give you, make sure we're all aware that this exists. Naloxone reverses the effect of opioid medications, and it is incredibly effective. And the really good thing about it is it is safe even if you are not experiencing an overdose. So often we'll say if you suspect, give naloxone and it's not likely to cause harm. Um, this is best utilized when you notice breathing is slowing or stopping, and it acts very quickly within 2 to 3 minutes, but it also wears off pretty quickly. So giving it is not the end, it's the start of the solution. So you may need multiple doses, especially if they took a stronger opioid medication. It's available as an easy to administer nasal spray or an injection. Um, One thing I have kind of a personal story to share that I think is interesting, that we now know that naloxone is available at pharmacies, both with and without a prescription for most of cases. But all pharmacies in Washington are able to provide it directly without a prescription. Folks don't always know that, so they may not know to ask about it, but anyone can carry it. You can also order the kits for free by mail. So folks who don't have insurance coverage, or maybe they can't get to a pharmacy, it can be helpful. So my sister broke her ankle in 3 places a couple years ago and was put on an opioid pain medication. And I went to pick up the prescription for her, and they also had prescribed naloxone. Awesome. Not everyone does that. And when we went there, they said they gave the opioid, told us how to use it, gave us the naloxone. They said, okay, my brother-in-law was with me. He's like, so how will I know when to use it? And they said, um, if she feels like she's overdosing. I said, oh my goodness. No one is going to recognize that. Naloxone isn't something you administer to yourself. So that would be something that a bystander or a family member would recognize. And the biggest thing to look for is that slowed breathing. So just keeping something like that in mind so you know how to educate someone else about it, I think is really important. Um, I also have had a patient at an assisted living community who once wanted to get rid of her naloxone because she felt a huge stigma having it. She thought that she was given this medicine because they thought she was going to abuse her medication. And I tried to explain to her that even if you take it as prescribed, that doesn't mean that you are safe always. There's always a chance of that overdose. Or what if a child comes into the apartment? Or what if someone else gets into the medication or doesn't realize it? Or you accidentally take the wrong amount. Having that on hand is so helpful as a safety measure, not because we think you're going to mess up, not because we think you're prone to overdosing or you're going to abuse the medicine. But that's another example of how that stigma can sometimes be, unfortunately, have a negative effect on our patients. And she ended up getting rid of that and didn't have that safety net available for her any longer. We worked with the higher ups of the assisted living community to make sure she was safe, of course, but realizing that that stigma is something that's really important to try to overcome. Um, so what the final note about naloxone is, once you administer it, you should seek emergency help. So calling 911, which maybe should be called before you give the Narcan in an ideal situation, but making sure we know that's just the starting off point. So next we'll talk about acetaminophen or Tylenol. Many of us probably think Tylenol is pretty benign. It's available over the counter. It's all over the place. A lot of folks use it. Um, and so that is an important thing to realize, that that's what most of the public is probably going to think about Tylenol too. It helps relieve pain and it helps reduce fevers. It doesn't help with swelling, though that's its difference with some other medicines. It's one of the most common medicines found in households, though. I bet a huge majority of us have some of it available right now in our homes. It's also an ingredient that we see in a lot of other products that have what we call combo products. So there's multiple drugs in maybe one pill or one liquid. Cough and cold medicines, flu medicines, allergy medicines, sleep medicine. They often throw Tylenol into them too. And so you might be taking Tylenol for pain, and then you take a Tylenol sleep medicine, and then maybe you've got a cold and you take your Tylenol cold medicine. They don't all say Tylenol on them. They don't always say acetaminophen in big letters. It's easy to accidentally take too much of this. If used appropriately, Tylenol is generally pretty safe and effective, but it can get to a toxic point pretty quickly. So when taken in excess, it can be life-threatening. The biggest concern is damage to your liver. Especially for those who are heavy alcohol drinkers, this could be a really big concern. So the maximum amount we'd want to take in a day is 3,000 milligrams or 3 grams. They say before we could do 4,000 milligrams, and now they say only if a provider is supervising you, so they can draw labs and stuff. But even 4,000, if that was our limit, less than double that gets us to a toxic dose if you do that in less than 8 hours. So if you take your dose of Tylenol and you're not sure if you took it and you double it up, over time you can get to a toxic dose very quickly. So what might that look like? Nausea and vomiting, just generally not feeling well, poor appetite, abdominal pain, you're confused, jaundice, so yellowing of the skin, your lab values may be off, which we're not going to notice at home necessarily, but the other thing is you could be asymptomatic, which is pretty scary. If it's less than 24 hours since you took too much Tylenol, we might not even know that that's what's happening. So there are different ways to approach overdose of Tylenol. You can try to prevent it from being absorbed. All of these need to happen in a healthcare setting. There's a reversal agent that you can give someone, or we just kind of wait it out and give them supportive care like IV fluids or meds to manage other symptoms. But this just shows how it is super important that we are aware that this can happen and that we need to seek healthcare, a healthcare setting to help us if there's an overdose suspected. One thing to note that the reversal agent, the N-acetylcysteine, is pretty awful. So we don't want folks to think, oh, if I take too much, I can just go take the antidote and I'll be okay. It smells and tastes terrible. It's not something you want to have to do, but unfortunately, it can be a necessity at times. So, not giving folks a false sense of security because the antidote is pretty awful. All right, next we'll talk about blood sugar lowering medicines. So insulin is something we may be familiar with. It's an injectable medicine. It does come inhaled, not as common though, and it lowers blood sugar for patients with diabetes. There is a really increased risk of overdose or getting your blood sugar too low if you're taking multiple diabetes medicines together, especially certain ones called sulfonylureas, like glipizide or glyburide. So the severity of the overdose depends on how much you take, the type of insulin, because there's a long acting, short acting, rapid acting, and the time since you ate carbohydrates or food that raises your blood sugar. So it's all a balance, and we're not really always able to kind of predict what the outcome will be if you take too much. So everybody's different body responds differently to different amounts of insulin. If let's say I have diabetes and my sister has diabetes, I could take 200 units of insulin per day. She maybe only needs 12 units of insulin per day. And if we accidentally switched things up, it could be really bad for her and I would end up with really high blood sugar. So it is drastically different in the amounts of insulin that patients need, patients can tolerate, and it depends on their disease progression. So taking too much insulin, what might that look like? You get a blood sugar that's really low, often less than 70 is our cutoff for what's called hypoglycemia. Um, some may be confused, have extreme hunger, they feel tired, sometimes irritable, shaking or trembling, sweaty and clammy skin. In severe cases, you may lose consciousness or have a seizure. Um, it's also important to note low blood sugar can be asymptomatic, so that can be really scary too. But someone who's running in the 300s, maybe their blood sugar's down to 100, they might feel low or they might have some of these symptoms, even though they're technically safe. It's not something that we need to rescue them with a medicine, but maybe they need to have a snack or something like that. So there's a lot of nuance that comes around diabetes medicines and insulin. But in general, if someone is in an unsafe situation, these are some of the symptoms to look for. How do we treat it? Um, we often call this the rule of 15s. You check your blood sugar, you have 15 grams of a fast sugar, you check your blood sugar in 15 minutes. If it's still low, you have 15 grams of a fast sugar. Um, but that would be for someone who's still conscious, able to eat, able to check their blood sugar regularly, and we continue to monitor. But maybe the more emergent or rescue type situations, we have other products available that are pretty cool. So back when I was in school and learning about these things, the only one that existed was one that you had to mix yourself. So you're never giving this to yourself. A bystander would be giving it. So let's say I pass out because my blood sugar's so low, and my friend comes along and says, "Oh, I need to give her rescue medicine." If she had a vial of powder and a syringe and had to stir it up and then draw it up and inject it, you could imagine it's a pretty stressful situation, not ideal. But that's all we had for years. Well, now we have ready-made, ready-filled pens that include the medication, where if your blood sugar's super, super low, or you can't take oral sugar and you've maybe passed out or had a seizure, you can inject this medicine. Um, there's also one that's just a nasal inhalation, which is so wonderful. So that one you just put into the nostril and click, click, and away we go. And your blood sugar is going to pop up from there. So really cool that we are seeing advances in things like this to help keep folks safe. Um, Unlike naloxone, these aren't really products that the general public is going to have access to or have available. So then it's important that maybe if you're working with folks who have diabetes and are on insulin, making sure they're aware of and have these medicines in their home or on their person, and they've educated those around them how to use it. Again, you will never give this to yourself because if you're aware enough to know you need it, you should eat sugar. We want to do oral ingestion first and give these in an emergent situation. Right, next is blood thinning medications. So, blood thinners are sometimes called anticoagulants or antiplatelet medicines. These help prevent blood clots from forming, or if you already have a blood clot, it prevents it from getting bigger. You might be familiar with warfarin, or some of these newer ones are Eliquis or Pradaxa or Xarelto. They also can help reduce the risk of a heart attack and stroke. And if you have something like a DVT or a PE, a pulmonary embolism, those are blood clots in different parts of your body. We might use some of these drugs to help with that too. Um, they could be prescribed if you have an abnormal heart rhythm or have had a heart valve replacement as well. So if you take too much of these, you could imagine we're trying to thin the blood. If we thin it too much, we're going to bleed. So internal bleeding, which we might not always recognize, or GI or gastrointestinal bleeding are both pretty severe issues that could occur. A stroke is one type of stroke is a brain bleed. That can also happen if you take too much. It's especially concerning if we take them with other medicines like aspirin or ibuprofen. And it's important to note that our risk of stroke increases with age, independent of use of blood thinners. So if an older adult presents, they already are at a higher risk, and then we put them on a medication that, if toxic, could cause a stroke as well, and that can be a concern. Um, Important to note there are two types of strokes, just to break it down. One is usually an obstruction or a lack of blood flow to the brain, and one is maybe a bursting vessel that leads to a bleed. So if you have too much of a blood thinner, patients might have heavy bleeding after they get injured. So you get a cut or a scrape and the bleeding just won't stop. Um, they might have pink, red, or dark brown urine or blood in the urine that is visible. Um, A GI bleed might look like blood in the stool, but not how you would expect to see blood. It actually ends up being black or a tarry type of texture of bowel movement. And that could be indicative of an issue higher up in the GI tract with bleeding. The severe stomach pain, as you could probably imagine, often accompanies a lot of these. So there are a lot of drug and food interactions with some of the medicines, specifically warfarin. So changes in the diet or a simple change in another medicine could cause warfarin to thin the blood too much. And that increases the chance of getting an overdose or into a toxic level. So this is kind of scary because it's not just a drug. It's not just this drug being too much. Other adaptations to your lifestyle and what you're eating and your activity could suddenly make a drug toxic for you. So there are reversal agents for many of these medications, but not all of them. But they do need to be administered in a healthcare or an emergency setting. So warfarin has a reversal agent, and so do a few of the others listed here. But not all of them have reversal agents right now. Some are in development, but often supportive care is our only option with those medications. So keeping in mind that seeking out healthcare or a healthcare setting is important. So let's talk about some harm reduction strategies. Um, Problems with medicine lists and medications are most likely to occur in transitions of care. So what that looks like is maybe someone's in a hospital and they're discharged to a nursing home or a rehab facility, or they're going from a nursing home to a rehab facility, or the hospital or emergency room discharged to home. So anytime you're changing care settings, there's a likelihood that an error could occur. That's when we tend to see changes to our medicine lists, right? You go to the hospital and they send you home on a different drug, or they changed one of your medicines. Maybe they stopped one of your medicines. And if that's not communicated appropriately, you could see how issues could occur. We also see issues arise after a doctor's appointment. Excuse me. So, especially if there's a change in medications or new prescriptions are sent to the pharmacy. When folks receive a new diagnosis and it requires treatment, that can also be an issue because they're often with a new diagnosis, we see physiologic changes in the body as well. Or maybe those symptoms go away when we start treatment. Just a lot of change happening. That's often our key. And that tells us maybe when we need to intervene or just have an extra set of eyes or pay close attention. So prevention is going to be a big part of this. How can I help prevent these accidental overdoses? And thinking about it in that context of transitions of care too. Encourage patients to keep a medication list and keep it updated regularly. So when a medicine changes or is discontinued, make sure the patients are educated to remove it, to dispose of it properly, but also change their list. Um, I will often have patients, if they're smartphone savvy, our older adult patients, put it in a note or take a picture of their medication list, but making sure they know where that's housed and they're updating it regularly. A few things that I think are really important to keep on a medicine list. And I know not everyone's going to do this, but the pharmacist in me would be remiss if I didn't share it all. But the name of the medicine, for some folks, it may be helpful to have both the brand and the generic name. Maybe they know one and not the other. So if you're helping someone develop a list, keep that in mind. The strength, and then how many of the pills you take or what the specific dose is, how often you're supposed to take it, and then what it's used for. There are often medicines that could have many different reasons for taking them. And if I assume incorrectly and I switch your medicine or something like that, that's not helpful. So, especially in the days of all these specialists and seeing multiple doctors, going to multiple pharmacies, it's important that we're putting as much info as we can on there. Accurate medicine lists are really important at every patient encounter, at every visit. If any change is made, updating that. So remember to include prescriptions, over the counter, vitamins and supplements, devices. People often forget those, like inhalers or nasal sprays, and topical medications. When we think about our what medicines do you take? Topical creams don't always come to mind. And while the interaction potential is pretty limited, there's a possibility. So keep that important thing in mind as well. Okay. Next, encouraging patients when it's feasible to use one pharmacy for all of their prescriptions. This can be hard, especially when older adults are price shopping. Medicare doesn't, well, now we have much better coverage for some medicines, but not always great coverage for all prescriptions. And so they might seek out different ways to get them less expensive. But if we can keep everything in one place, it allows that pharmacist to do a safety check. They have the full list, they know exactly what it looks like when that patient goes home to take medications, and it helps keep our patients safe. If you know a patient tends to shop around for better prices, telling them to keep a medication list is extremely important. Um, so we talk about these pill boxes. They do have some pros and some cons that can help here, and we'll talk about that in a moment. But sometimes we'll say if you're using a pill box to only fill them 1 week at a time, make sure you keep them out of reach of children and pets, because once they are taken out of their bottles and put into the pill boxes, it's no longer childproof. So if you are going to use these products, we encourage you to keep them up and away from your from kiddos so that they can't access them. So it's really important to educate patients, encourage them to take their medicines as prescribed. So follow all the instructions, read the instructions carefully, especially when you get a new prescription in case something changed. The pharmacy might have altered it and told you to take half of a pill and they gave you a bigger one. Hopefully they'd notify you if those things happen, but reading labels carefully is really important. Read the information leaflet if that's something that intrigues you. For some folks, a magnifying glass can be really helpful. Our eyesight doesn't stay as strong as we get older. And so maybe you look at the bottle and you see an S and you think, oh, that's my medicine that starts with S, and it's actually your other one. Not being afraid to use a magnifying glass is really helpful. We encourage patients not to take medicines in the dark, always turn a light on. And then making sure you're measuring them accurately. So don't use a spoon and assume it's the amount of a teaspoon, right? Using the provided measuring devices. So one thing to help prevent accidental overdose is deprescribing, which is a big push in older adults. Now, we may not all be prescribers, or any of us we may not be prescribers, but that doesn't mean we can't help. Encourage patients to talk to their providers about maybe reducing the number of medicines they're on, reducing the dose of some of their medicines, especially if they've said, like, I feel like I just take so many medicines. I have so many pills. Encourage them to mention that to their doctor and have them work together with their care team. Um, it's a really common thing that we work on for patients as they age, and make sure that our prescribers are taking a lot of different things into account. One thing I tell my patients is if a doctor's starting a new medicine or you have questions about something, I always say, did you consider my age when you picked this medicine for me? Because it might be the best treatment for someone in their 50s. And maybe this person presents young and they didn't happen to look at the age, and they prescribe a medicine that maybe not the safest choice for someone who's in their 70s. Reminding your provider that, hey, I'm of a certain age and I want you to look at that detail as well to keep me safe. To help patients avoid drug interactions, we always say avoid mixing medicines with alcohol. Not all medicines have a direct interaction with alcohol, but if we keep that as a general concept for folks to appreciate, it can be helpful in reducing potential risks. Avoid mixing other substances and vitamins without first talking to a prescriber or a pharmacist. Don't stop, start, or change any medicines or any doses without talking to your prescriber or pharmacist. Appropriate storage of medications is important. So we always say keep them in a cool, dry place, out of reach from kids and pets. Most older adults over 65 don't have young kids in the home, but some do. And some may have grandchildren living with them or visiting them regularly. So one important resource we use is up and away. So keep things up and away and out of sight. So a high up kitchen cabinet is a great place. Medicine cabinets are not a good place, both because they're accessible and bathrooms often have a lot of heat and moisture. Think warm showers, and that's not great for the integrity of medications. So places to keep them could be a kitchen cabinet as long as it's high and out of reach and out of sight from children. the top shelf of a closet, maybe a bedside table drawer if you can lock it, or often they make lock boxes for medicines as well that may be a helpful place to keep them. Take extra care with the following medicines, kind of the things we talked about are Tylenol, opioids, and diabetes medicines. So sometimes we know accidents will happen. What do we do then? If we suspect an accidental overdose, 911 is our first call, especially if someone is experiencing some of those concerning symptoms that we talked about, or if you find someone down and there's a suspected overdose. So those big concerning symptoms, as a reminder, are if a patient stops breathing, they have a seizure, maybe they collapse, or maybe even just slowed breathing could be enough to warrant a call. You could also call the Poison Center. Again, that phone number here should be ingrained in all our minds at this point, I'm sure. But if there's been a poisoning, but the person has not stopped breathing, they haven't collapsed, they have not had a seizure, the Poison Center could be a good place to go or to call. If you're concerned about possible poisoning, it can be helpful if you realize you've taken too much of a medicine, but you don't have any symptoms that need immediate attention. So maybe you took a double dose of your medicine and you immediately realize it, or the wrong number of pills, or too many puffs of an inhaler, or whatever it might be. The Poison Center is a good first call to know if it's warranted to call 911 or not. You can also talk to your prescriber or pharmacist if it's a non-emergent situation. So maybe you realize a patient has been taking the wrong dose of a medicine for a while. It's not an emergent need. It's not maybe a poison center call. Maybe you think some of the side effects that they're experiencing are from a medication, or maybe taking too much of a medication. Calling the doctor or the pharmacist could be a helpful resource then. So lastly, a quick summary here. Accidental overdoses unfortunately do happen and can be scary, especially in our older adult population. So the risk that's associated with prescription medications can increase as we age, and the risk of accidental overdose can increase as the number of medicines that we take per day continues to grow, which tends to happen with age as well. There are actions you can take to reduce your risk and patient risk of an accidental overdose. So, when in doubt, talk to your prescriber, talk to the pharmacist, encourage the patients you work with to do so. And then it's always important to know what to do in case of an accidental overdose. So, when in doubt, calling 911 is your safest bet. And with that, I'm happy to answer any questions that folks may have.
Sure, and if folks want to, they can put their questions in the Q&A box. I just had one briefly for you. I think your slide said about 50% of people in the US 65 or older consume 5 or more meds daily, polypharmacy, right?
Yeah.
So question is, how does medication use in aging populations in the US compared to other countries? Are we consuming similar amounts or not? And what do you suppose the contributing factors are to this?
Yeah, great question. It depends on the country. But one thing I can say is there are a lot of other countries that also have huge de-prescribing efforts going on, which lends us to believe that there are issues other places as well. Canada and Australia are big ones that come to mind. I think the biggest thing that leads to this is as we get older, also, first, we're living longer in general. But as we get older, we're more likely to have a new diagnosis. With a new diagnosis comes a new treatment. As we get older, different parts of our body aren't working like we expect them to. And medications are often things that can help us overcome some of these pain, like daily pains that we have, or, you're trying to find that magic supplement to help with your brain health or whatever it might be. So sometimes we're looking for that magic cure. Sometimes we've just got a lot of new ailments. Sometimes it's just that we're living longer, and as bodies get older, they have more concerns and more diagnoses, which means more medications. So the United States is not alone, and I think it is more an age concern than it is like our society or anything like that.
Thank
Um,
you. We have one. Oh, go
yeah,
ahead.
I did see a couple questions here. Did you want to monitor those or?
Sure.
Okay.
So I saw one in the chat. Basically, it comes down to an overdose from opioids closely mimics the blood sugar low from a diabetic. Would you administer naloxone first, and is it safe for a diabetic if you have no inclination they are diabetic?
Mhm. Yeah, that is a wonderful question. I think first, the biggest thing to note is if someone has diabetes and they are on insulin, it is, I mean, I would really strongly hope or expect, want them to have some sort of indication of that, whether it be a medical alert bracelet or they're with folks who know they have diabetes. That is generally my first go-to. If you know someone has diabetes, that's what you think is going to be the issue, because giving sugar is much safer, much easier than going the naloxone route. Um, if you're not sure if someone has diabetes or not, I think the big symptom I look for with opioid concerns would be slowed or stopped breathing. That's not likely to occur in someone with a low blood sugar. There's other things that will happen first. Um, the good thing about naloxone is, as we said, if there is any suspected, if there's any chance that you think there's a suspected overdose of an opioid, naloxone is safe to give and is not likely to cause harm. And that's kind of what I go back to, but um, keeping in mind, like asking those around them, maybe checking a bag for diabetes supplies or something like that could also be helpful before you just quickly administer an unneeded medication. But as far as the symptoms being similar, again, I would look for the breathing being the biggest one with opioids. And with diabetes, it would be more, and the lethargy is sort of common for both. But the confusion is another one, I think. Did that do you answer well enough, you think?
I think so. And if there's any follow-up questions, feel free to pop them in the
Mhm.
Q&A box for our participants here. Can you discuss the link, if there is one, between prescribed opioid use and falls?
Prescribed opioid use and falls. Yes. So opioids will, as we mentioned, they can cause some drowsiness. And so the biggest thing with opioids is when it's when there are interactions with other medicines folks are taking. That's maybe our biggest concern. So alcohol, benzodiazepines, other some psychotropic medications, anything else that can cause drowsiness when paired with an opioid is more likely to then increase the chance of a fall. Um, the opioid itself can also do that because you might not realize you're drowsy, or maybe you are not feeling a pain that then maybe you're unsteady and that can lead to a fall. So it's both a cognitive kind of awareness and being drowsy issue, but it can also be a physical concern if we're getting rid of that feeling of pain, and maybe the feeling of pain is the thing that helped you realize you were close to falling or needing to catch yourself or something like that. Um, does that answer the question?
I think so. And then I have one final question. What is a single action step you would like viewers or attendees to take after watching your session today?
Hmm. Don't assume medicines are safe. Um, I think, which is kind of general, but especially with older adults, ask that extra question. Don't add that extra medicine without talking to someone else. Um, and always verify the dose and that sort of thing. So don't always assume safety. Don't always assume that you know what you're doing. Double check yourself all the time.
Excellent.
Yeah.
All right. Thank you so much, Dr. Winter. I mentioned to you previously, I was a caseworker for Medicaid for many years before this, and I saw firsthand the issues of medication management and everything that you discussed, and how it impacts a person's life. And so I think you shedding light on this and sharing your expertise is really helpful. There actually is one more question.
Mm,
Sorry.
that's
The
okay.
diabetic pens you mentioned, are they available over the counter?
No, unfortunately. I wish they were, but I think in general you would not have trouble getting a prescriber to prescribe that. But if you don't have diabetes, it's not going to be covered by insurance and that sort of thing. So someone with diabetes could get that prescribed. It should be covered under their insurance and they have access to it. But for the general population, it's not likely that you'll be able to access that.
Okay.
Yes,
Excellent.
hopefully, maybe.
Right. So again, thank you so much for sharing your expertise. I hope that folks got a lot out of this. I think it's important, especially with our loved ones too, and perhaps our parents, that we be as nosy as possible and ask questions and be that second set of eyes, and really try to help out. And I think you gave us some great guidance today. We'll turn our cameras off and stop the screen share, and we'll hand this over to my colleague Alex Saratsky, this is the last session today. He'll be sharing some closing thoughts and wishing you all well. So thank you so much. And
Thank you.
All right. Thanks so much, everyone. Thank you so much for being here. Um, oh boy, it is a heck of an honor, but also a heck of a task, heck of a job to provide closing thoughts following such a great presentation from Dr. Winter there, and following so many great presentations and sessions throughout the series for today and for the other days we've hosted this. But I'll do my best. We'll. Um, there's the typical closing logistics of, again, take that survey if you want that certificate of attendance. We are done with sessions for this year's series. So if you have not filled it out for today, now is the time to do so. We're also going to have our recordings for every single session posted on our website soon. I believe we have both days 1 and 2 all ready to go on the website there. We should be getting the rest over the next week is our goal. And I want to just, I have to give a plug for the Poison Center. And I think Dr. Winter did such a great job of plugging the Poison Helpline. But again, for any questions on any poison, whether it's an active poison emergency, providing the patient is breathing, responsive, and not having a seizure, or just to ask a question to prevent a potential emergency, please call the Poison Helpline at 800-222-1222. I also want to just give massive thanks and gratitude to every speaker for this year. Every single session, I think, has been so rich and so full of their expertise. We really could not do the series without our partners' support. And I want to give a more specific thank you and shout out to our colleague and friend, Megan King. She is the director of public relations and education. Justin and I have had the pleasure of working with her since we've both joined the Poison Center, me back in 2019 and Justin this last year. And the Overdose Awareness Series would not happen without Megan, period. Not only would it not happen currently, but it never would have started to begin with. The whole idea started with her. And it really started when before Justin was able to join us back in 2020, Megan and I were tasked with, all right, do education, but remote. Back when we were in the heat of lockdown, the heat of those first few waves of COVID. And Megan had this simple but profound idea of we should do something around International Overdose Awareness Day. And jump all the way to now, where we've hosted 5 consecutive years of this series, reaching literally thousands of Washingtonians, excuse me, as well as folks from across the country. Shout out to any other Poison Center educators here. Over dozens and dozens of sessions covering a wide variety of topics, all pertaining to overdose prevention, harm reduction, and treatment. So I'm especially grateful for what Megan does. And even today, she Justin and I pour a ton of work, ton of ideas into this, and Megan always holds the lion's share of the organizational work, making sure that the platform is good to go, making sure that all the emails are ready to send out. So when Megan's not able to be in this particular session, she's on her way to a very well-deserved vacation. But when she watches the recording here, Megan, thank you for everything you do. Okay, now I'll keep the rest of my reflections short and concise and not hold you hostage for too much longer in your afternoon. But as I reflect on all of these topics, on all the folks who show up here, it can be really easy for me, especially, but I think all the organizers on the back end with the Poison Center, when we're leading up to any year's series, to be so focused on the logistics. Oh my gosh, are the links ready to go? Is the platform going to work? What happens if the laptop crashes? That happened last year. What do we do in all these different contingencies? And so there's that dissociation, I think, that can happen from an organizer's perspective and the actual content of what we're trying to share out with everyone. And for me, every single year there's this click point, and it often happens in one or more sessions where I just very suddenly feel all of the weight, all of the impact from these topics, both the emotional heft as well as the very intentional hope and the very intentional desire to help and do good and reduce harm and prevent harm wherever possible. And I think one of my personal big takeaways is that when when we're faced with all these very, very dire realities around substance use, around overdose, over a variety of substances, it can be so easy to get lost in that. And I think, you know, one of the sentiments I have seen a lot this year, especially, I feel, is that one of the surefire ways to combat those barriers is through community, through connectivity, through communication, through supporting each other. So the last thought I want to leave you with, beyond gratitude for being here, beyond gratitude for the work you're doing on the ground, every one of these attendees, is to maintain that community wherever possible, to maintain that connection, to reach out to your existing communities and help them where you can, and to ask help from them where you can, because I think that is how we keep going. That's how we change these systems that don't serve everyone equitably. And that's how we help prevent, reduce harm from, and ultimately treat these different overdose situations. So I will stop myself from continuing on too much further, and just want to say thank you. Thank you all for being here. And I so hope to see each and every one of you and more for next year's series. Take care, everyone.